Thank you very much. And sorry about all the changes with the timings. And thank you for coming on a unusual day for this session. Um, so the topic that I'm going to be taking you through today is gender inequity in palliative care, but we're also going to cover a little bit about gender inequity in healthcare as we address this. So I think I'll just go directly into it and share my screen. And just one second. Just give me 1 minute, please, Manisha.
Yes, ma'am.
Okay, is this all right? Is this clear?
Yes, ma'am, it is.
Okay, so I know that in earlier sessions we have covered equity, but we're going to look specifically at equity through a lens of gender today. And as we go along, we will also talk about different spin off areas. So, just as a disclaimer, I'm not going to only be talking about palliative care, although that will form the crux of it in later part of the session. But I'm also going to take you through what it looks like in healthcare in general. More and more, we are seeing that palliative care and healthcare are intimately connected, and a lot of the um, areas of concern that we address in palliative care largely impacts healthcare or health equity. So I'm just going to you know let you all know in advance that you'll find that a lot of the stuff that I'm covering today uh, is applicable not just to palliative care but to healthcare in general. So before we go into what gender equity or gender inequity looks like, I think we need to just pause for a moment and understand what the difference is between sex and gender. Now, some of you will, or all of you, I hope, will remember the session that we had with Dr. Samira, who talked to us about the LGBTQI um, issues, and in that she had quite beautifully illustrated what the difference is. But just to reinforce the point, gender is culturally defined, and while traditionally all of us think of gender as male and female, we now accept and respect the fact that gender is not just anatomical, it is culturally defined, and it is defined by roles and responsibilities. So typically, traditionally, a female gender is associated with caring and service oriented roles and responsibilities, nurturing, looking after others, and so on. What we attribute to the female gender typically when we think of female, of course, some of you might disagree with this now because we look at it differently, but I'm talking about traditional perspectives, is that women or the female gender is allowed to be more emotional, is considered to be weaker, is considered to be fragile. Of course, all these are now being upended in many ways. And what we find is that those of the female gender typically are more financially dependent or receive inferior healthcare to men. The male gender, by comparison, attributes of a masculine gender are more, risk taking, aggression, assertiveness, roles and responsibilities. Typically, traditionally, if you look at it, it will be that of a protector or a, so defense, and a provider, construction, things like that. And we see that they have a higher workforce participation because typically it is the men that are expected to be the, like I said, the providers, and they're the ones who go out and work, and a woman is expected to, in many cultures and societies, be the one who minds the house. And a lot more financial autonomy is associated with the male gender. Now, gender, like I said, is culturally defined, whereas sex is biological and it is determined by chromosomes, by reproductive organs and genitalia, by hormones, by by bodily attributes. Now, of course, I'm not going to get into the other genders that are now emerging, because that would just be a repetition of what Samira has already taken us through. But just to sort of set the context, that when we talk about gender, we're not talking about the traditional anatomical differences, but we're talking about the roles, responsibilities, and the perceived ideas that we have associated with gender. So this is a infographic that was found in the Lancet, that was created by the Lancet. Okay, now this is something that in international health that has been acknowledged, that an inclusive approach to health should attend to the needs and differentials between men, women, and other genders, along with the interaction between social and biological markers of health. So it's not just that okay, everybody should have access to healthcare, but we have to understand that the needs of each of the genders are different, that there are differences that exist between different genders and what they need in terms of healthcare, and what they're entitled to in terms of healthcare. And also that there is it does not exist in a vacuum, because there are very strong social and biological determinants that play a role in defining these things. So I'm going to just let you read that sentence for a couple of seconds, and the rest of the presentation will also highlight what exactly this bunch of sentences is referring to. So a few key definitions, so that the rest of the session is a little bit easier to navigate, is that there is something called gender equality. And this is something that we hear about a lot. Now, I'm talking about this purely from the perspective of health. Now, gender equality refers to the equal enjoyment of good health by men and women of all ages, regardless of sexual orientation or gender identity. So basically, equality is something that everybody it basically means that everybody has the right to health. And they've made a specific mention of regardless of sexual orientation or gender identity. I might be a woman who identifies as a man, or I might be a man who identifies as a woman in terms of gender, in terms of my cultural roles, in terms of my my attributes and things like that. Or I could be a woman whose sexual orientation is towards other women. I identify as a woman, and I'm sexually oriented to other women as well. So that would be a lesbian. Or I could be a man who identifies as a woman and is attracted to other women. So all of those things we're not going to get into at the moment, but this is just to say that gender equality is basically for everybody, irrespective of those aspects. Then there is something known as gender equity. And here is uh, a sense of fairness to the different health needs of men, women, and other genders. So it's not that everybody should get the same thing, but everybody should get what they need. And that could be that is very different. So it's not that if the man gets XYZ, then the woman also has to get XYZ. That XYZ may not be what she needs. She might need ABC. So gender equity has to do with a fair allocation of available resources to people from different genders. Then there is the idea of gender mainstreaming, which means, which this has to do with designing policy that that is in line with uh, the health concerns and experiences of people from different genders. So it's not just what is given, but what is the framework within which these needs are assessed, they're evaluated, and programs are implemented that will specifically target specific needs of men, women, and other genders that are in existence. So if you remember Samira's presentation, she talked very lucidly about the fact that the transgender community's needs are not very obvious to us, not very visible to us, and also it's not visible to the healthcare system. And that is one of the things that the trans community is fighting for at the moment, to be visible, that for their needs to be made visible, so that appropriate policy can be framed and appropriate programs can be designed and implemented in order to meet those specific needs. And that applies to all genders. So mainstreaming basically talks about how we come at it from a policy perspective, from an implementation perspective. And finally, the idea of empowerment. Empowerment is a slightly tricky concept, in my opinion, because what it really talks about is enabling
I'm
individuals and
attending class.
communities,
Marvin Pondicherry.
enabling individuals and communities to gain more control of their lives and to shape systems around them. So uh, there is a fine line between empowering somebody or being paternalistic towards them, and treating them as though they were lower down in the hierarchy. So there is the saying that I've often mentioned, that compassion is not a relationship between the healer and the wounded. It is a relationship between equals. There is a sense of equality there as well. But empowerment, a lot of the times, it has a downward cascade from people with access to more resources, with access to more power, and therefore there comes the system itself sort of reiterates that. So it's very important that we're cautious when we talk about empowerment. It doesn't make us better than the people that we are empowering or enabling. So these are four concepts: gender equality, equity, mainstreaming, and empowerment, that I'd like you to bear in mind as we go forward and talk about, what gender inequity looks like in healthcare and in palliative care. Now, to attain more universal coverage, and this is something that we've been talking about a lot. I think I've skipped a slide, but okay. Universal coverage. Basically, what does universal coverage means? That everybody has access um, to the available resources, and to appropriate healthcare, and to appropriate and affordable healthcare. And to attain more coverage, we have to achieve gender equality. We have to understand that everybody has a right to it. And universal coverage does not mean that only those who are more visible get it, and those who are invisible fall through the cracks. So it is essential to achieve gender equality if we want to assure that there is better universal coverage. And gender equality can only be achieved when there is gender equity, when there is mainstreaming, and when there is empowerment. So when we recognize all those definitions that I just took you through, this is it's actually backwards. So once we understand gender equity and ensure that it takes place, mainstreaming is done. Gender is considered. We are sensitive and sensible about including gender differences and differentials when we create programs, and then make sure that when the program is implemented, those who are not at a position of power are also empowered, are enabled to take control of their decisions, that they have the ability to make decisions regarding their health and so on. And then we will achieve gender equality, and only then will we have universal coverage. So this is a catch-22 situation. This is one of my favorite depictions, and I think you must be familiar with it. This is the difference between equality and equity. Equality is giving everybody the same thing, but it doesn't achieve the same goals, because we're not looking at it from the point of view of the recipient. We're looking at it from the point of view of just doling out stuff that we think everybody needs. And this is where empowerment also becomes tricky, because when we might be thinking that we are empowering somebody, but we might be giving them something that is not what they need in that moment to truly be empowered. Equity is understanding that everybody's needs are different, and then responding to those needs accordingly in a way that is appropriate and respectful to what they want and what they need from us. So this is the, if there was a clearer way to explain the difference between equality and equity, I still haven't come across it. So this picture has stayed with me from the time I have encountered it. There are several reasons why gender inequity exists in healthcare. And now, although I said that traditionally we have looked at gender equity as being, the role of women, uh, the previous few slides that I showed you were to highlight that it's not just men and women, but there are other genders also involved. But for the purpose, for just for practical purposes, I'm going to specifically allude to the to women in this context. Um, there is an inherent lessened value for a girl child when a girl child is born, and that's because of archaic traditions like dowry and all of those things. I mean, even sati for that matter, and like dowry, for instance, dowry came from the idea of stridhan, and stridhan was it literally translates to a woman's wealth. So when a woman married into another family, she was given things that she needed, but over a period of time this got distorted into into an idea of dowry. And as we all know, that dowry is quite a I think, in my personal opinion, quite an abhorrent system even now, where because of which a woman undergoes various traumas once she is married. And because when a girl child is born in certain cultures and certain families, they're already thinking of what it's going to cost them to get her married off. And so she's already considered a burden. uh, we do, whether we like to admit it or not, exist within patriarchal norms. And by and large, if you look across the country, if you just pick up the newspaper and you read it, there are, on a daily basis, there are depictions and illustrations of how these patriarchal norms create a lower status for women. And so women are treated differently because of the pervasive norms being inclined to serving the needs of a patriarchal society, where men are the focus and the center of it, and men are the ones who are empowered. There are traditional role expectations, nourisher versus provider. And like I said, gender wise, the female gender is considered to be the nourisher, whereas the male is considered to be the provider. And while these norms might be broken in a lot of families, in a lot of our own families, by and large, unfortunately, the larger landscape is dominated by this sort of a role expectation. And you will see this even when the husband and the wife are both working. When a child is born, it's usually the wife who's, because she's the mother, she stays, she quits her job, she takes care of the child. And that is understandable to a large extent. But suppose an older person falls sick within the family, and they could be a blood relative of the man. uh, in a lot of cases, it'll still be the woman who is expected to give up her job, be at home, and look after the person who is unwell. So these kind of role expectations do exist. And further down the line, I will be talking in more detail about that. Women traditionally have a lower share of household resources. And it is a it is a it is not the norm for the woman to be the financial decision maker. It is usually the man. And and that's across the board in a lot of cultures. And because she's allocated a certain amount of money that she can use every month to run the household, or to make sure the machinery and the engines are running at home, she is very likely to use that money less on her own health. So because she has to take care of so many different things, her health kind of slips down uh, the priority list. And we all make jokes about this. I suppose at some point or the other, we've heard these jokes about how a woman's threshold for pain is higher, and how women respond to illness in a more stoic way, or whatever else it is. And that may not necessarily be true, but because these sort of ideas exist, sometimes we live up to those ideas and norms, and society is more accepting of those ideas and norms. So a woman accesses healthcare a lot less because she has a lower share of the household resources. Um, Typically, a woman has lesser decision making capacity, and this is tied in very deeply to to all the previous points above this one: the patriarchal atmosphere, the role expectations, resource allocation. All of these things lead to the fact that the woman typically is has less decision making capacity in terms of financial decisions especially. And because of that, there is an inherent inequity that exists when it comes to healthcare as well. um, it's a known fact. There is evidence for the fact that women underreport illness. A woman is less likely to report that she is feeling sick or she needs some time off, or it's not just from work, but even from her household chores. Because she has so many things to do in the day, because she has so many responsibilities that apparently nobody else can do, they also underreport illness and are usually the ones who'll stick it out for longer before things get bad, and and then they go and access healthcare. Um, a lot of well, we do have our primary health system and stuff like that, but typically, if you look at it, the more high tech healthcare and the more advanced healthcare is concentrated in urban areas, and far less women doctors are deployed in rural areas. Now, why does that make a difference? Because if a woman has a problem, if there is no woman doctor in the area, she's less likely to visit the clinic. And it's not just by her own choice, but she either has to be accompanied by a man to go see a male doctor, and if the man is away, he's at work, then that gets put off. So it's very difficult for a woman in a very remote or rural area to access healthcare when there are fewer women deployed there. And why are fewer women deployed in rural areas? It's because it's considered, it's not a posting for a woman to take alone. It's an unfamiliar territory, and most women are not supported enough when they go out into remote areas or rural areas to work by themselves. And I've seen some brilliant women out there in the field working in rural areas, and I can also tell you that those are women who come from circumstances where they're supported by key people in their lives, including their husbands. So healthcare is concentrated in urban areas, making it difficult for women to access healthcare there. Difficulty in traveling alone in public places. I'm going to just uh, wait for some responses to come in the chat box. And why is this difficulty traveling alone in public spaces? I'm talking specifically about the Indian context and a lot of the LMIC context. Why should this impact a woman's access to healthcare? Can any of you contribute to that? You're welcome to unmute yourselves. We can have a small discussion around these things that I've just shared. Vulnerability increases. Yes, that's right. Safety is an issue for sure. Any more responses? Just going to a healthcare center by yourself. I mean, we may be able to do that in the city, but in some of the more rural areas, that may not really be a possibility. Fear, yes, that's right. There is fear. One only has to take a look at the news to understand that that fear is not unfounded. She's dependent, and other family members are dependent on her too. Not being comfortable. Safe, yeah. So there are more responses coming in. Okay, so I'll let that continue. So yeah, this definitely has an impact on a woman accessing healthcare. Less participation in the public sphere, less political participation. Why is this? Why is this an important component in gender inequity? Remember what I said about mainstreaming, gender mainstreaming, policies being framed. So when a woman participates less in the political sphere or in the public sphere or in the policy sphere, there is less representation of their needs. And this is true not just for women, but also for transgender communities and other communities or other gender, people from other genders, where there is less participation. So she's not in that decision making capacity to represent the needs of the community. And therefore, the policies don't very often exclude some of the more nuanced needs that that women and transgenders and other genders might have. We find that there are also higher rates of depression and some mental health conditions because of social and cultural factors. And when that happens, it is a debilitating state. um, so getting help for things like depression and mental health conditions is not a priority in India by and large anyway. But women slip further down that scale because you'll find that women have a higher rate of depression and mental health conditions. So when that happens, they're not accessing healthcare. Depression also leads to other health issues, other physical health issues, and so on. So it compounds the whole suffering. It compounds the inequity and it makes it even worse. And we find that there is also higher instance of domestic violence against women that goes unreported, either as acceptance as norm or to avoid shame to family. And I think this is something that all of us can quite easily understand and grasp, that violence against women leads to health issues, it leads to other issues. And because of cultural norms where we make it very difficult for a woman to actually report these events, that leads to other health conditions. So that is also a leading cause of inequity in healthcare when it comes to a gender sort of from a gender lens point of view. um, I'm going to just stop for a moment here and ask you to reflect on some of these points that I have made. And you can tell me if there is something else that you can think of, or if there is something that you'd like to, an experience that you'd like to share that has validated or highlighted or emphasized any of these points that I've talked about. I'll be getting into some of the other key areas in a little while, but just around this these two slides, if there's anything that anyone wants to talk about, then I'm happy to spend a couple of minutes here. Okay. I think it's probably at the end of a day for a lot of people, so I'm not going to press the issue. Women in our culture themselves in homes greater priority to the health of others than their own. Yeah. Yeah. The minute the child gets sick, child gets attended to. The minute the husband gets sick or the older parents get sick, there is attention. Yeah. Isn't gender equity improving? Um, well, yeah, that's an interesting point, Rajni. Gender equity, I would say, is improving. There's a lot more conversation, and I think thanks to social media and thanks to a lot more people being more vocal about it, there is and more education. There's a lot of intersectionality with education, with advocacy, and so on. So it is improving. But I wonder, I'm going to ask everybody else in this group to also comment on it. Is it moving fast enough? I won't say that we're still in the dark ages. And I also need to put out a disclaimer to all the wonderful men here who are at this session, that this is not a, um, uh, antagonistic perspective. It is just a statement of observation and evidence. But there is of course a whole section of society that looks at things differently and is very enabling in that respect. But not fast enough. But definitely far better. Yeah, definitely far better. A long way to go yet, though. Okay, so I'm just going to zoom out a little bit now, and I'm going to go into the world arena where we talk about sustainable development goals. And I think all of you are familiar with SDGs, which is basically a collection of 17 interlinked global goals designed to be a blueprint to achieve a better and more sustainable future for all. And this was something that was announced in at the United Nations Development Summit in 2015. And this is something of a buzzword now, sustainable development goals. Now, under these goals include things like climate and all of those things. And under that, one of the sub goals is universal health coverage. And we have talked about universal health coverage a few times here in this series, and it is a sub goal under sustainable development goals. Now, what does universal health coverage really mean? I'm sorry if I'm preaching to the choir here, and you all might be already familiar with this, but it bears restating once. The word universal implies that it's for everybody, it's for everyone. The basic tenet of universal health coverage is that it's built on equity and fair allocation, which implies that people with higher needs, such as pregnant women, young children, the chronically sick, should receive more services than others. That is a pipe dream still. I think we are working hard, and it's one of the reasons why we say that palliative care, in the way that we see it and the way we practice it, can actually be a bridge to universal health coverage, because we pay special attention to these highly marginalized and vulnerable groups who are outliers in the healthcare system. So it also talks about financial protection, that people should have access to appropriate healthcare at an affordable cost. It's not just enough that certain services are available, and we've talked about this on other forums also, where something might be available but it is not accessible. And why is it not accessible? Because most of the time it is not affordable. There might be a cutting edge intervention available for the kind of disease I have, but if I can't afford it, then what's the point? I can't access it. So accessibility and availability can only be bridged by affordability. And universal health coverage very strongly talks about the fact that everybody, so universal, everyone has the right to appropriate care and good quality care at an affordable cost. And that is what universal health coverage means. And it's actually very essential to the idea of gender equity, because if we don't achieve gender equity in healthcare, then we are nowhere close to universal health coverage. And that's why it's important to look at gender equity in healthcare under the stated vision of universal health coverage, which is again embedded in something that the whole world agrees upon in the Sustainable Development Goals. So while the larger picture is quite idealistic, the ground realities, we still have a lot of work to do. And here's a statistic. The World Economic Forum ranked India 132nd out of 134 in terms of gender equity in health. So that just tells us what a long way we still have to go in order to achieve some of these goals. Okay, so there are some comments in the chat box that I'm going to come back to in a little while. Okay, now women and health right through the life cycle of a woman. Now, again, like I just want to reinstate that we're specifically going to be talking about women here. Right through the woman's, a female's life cycle from the time she's a child, is a baby, to a child, to an adolescent, to an adult, and an older woman, and then going into old age. There are several health challenges that can come up, which are very specific to the fact that they are women. So can I invite you, before I go into it from my side, what you think? Let's talk about babies. And I know some of you are very familiar. You're working in pediatric palliative care. I know that some of you work with some of your doctors and counselors. So let's start with this. What are some of the issues that children, like babies, have because of the fact that they're a girl child? to pull up the safety issues. Undernourished. Yes, Lakshmi, spot on. Undernourished. Safety issues. Sandhya, can you elaborate a little bit on what safety issues you might be talking about? Any more inputs from anybody? Okay, why would a child be undernourished just because she's a girl child? It is a big statistic, by the way, the undernourished. Um, Manisha, can you see my PPT still? Is it still visible?
Yes, ma'am, it is still visible.
Okay. We actually have data that says that from 2005 and 6 that talks about the fact that uh, while neonatal mortality is higher in boys, post neonatal mortality is higher for girls. Larger allocation of resources for the male child, yes. Female infanticide, even before she comes into the world, yes. Absolutely. Yeah. So neonatal mortality, post-neonatal mortality is higher in women, and this is in girls, and this is a known statistic from 2005, 2006, and this also highlights the discrimination and the disparity that exists even at that age. So that's one of the health-related issues that we see, and because they're undernourished, they develop all kinds of other ailments and issues. What about children? What about childhood? Pretty much the same. Um, Girl child is not treated the same way as a boy child. Yes. So you'll find that there are a lot of similarities in. I mean, from the post neonatal time to when a child is young. What about adolescence? What happens when a girl child becomes an adolescence? Um, yes, Vandana, sexual abuse is a big problem also, but I would say that sexual abuse is not only limited to girl children. Of course, we know a lot of horrific stories of even young boys are victims. Girl children are viewed as some sort of liability. Differences in sending children to school, yes, and that affects not just their education, but also it has a massive impact on the opportunities available to a girl as she grows up. Yeah. You also find that one of the statistics that we have is that complications in pregnancy is one of the leading causes of death amongst girls between the ages of 15 and 19 in India. That statistic is still amongst us in 2021. So Linda has talked about housework. Yes. So I would say physical labor being put towards physical labor does impact the child's health, a girl child's health. Yeah. We have a lot of places in India where girls are married off very young, and they are not really equipped to be mothers at that age. That has not just physical health issues but also mental health issues. Being treated differently during times of menstruation. Thank you, Jade, for bringing up a very, very, very valid and important point. Menstrual health is a huge concern in many parts of the country, even today. And that is one of, I would say, menstrual health and hygiene is an incredible problem. If you look at even if you look at menstrual hygiene needs, like if you look at sanitary pads and things like that, they're not even available to a lot of the girls in or women in very rural areas. In fact, there's a really interesting group that has come together called ASAN, and it's run by a very young woman. She's in her late 20s. She's come up with the menstrual cup, And I can share a video with you later as part of the return learning material that we share with you. Please remind me, Manisha, where this is actually taken off quite beautifully in Karnataka. And for every urban woman who buys one of these, which not only is hygienic but is also good for the environment, they donate one to a rural to a woman in a rural setting. And we have a video of the women talking about how something as simple as that has altered the course of their lives in many ways, allowing them to do many things that they weren't able to do before. So, menstrual health is a big one. Thank you, Jade, for bringing that up. And yes, they're ostracized. Um, in Nepal, as I mean, I'm sure that at least some of you might have come across that news where a girl she died because she was put in isolation during her menstrual cycle, and those kind of uh, traditions and superstitions still exist. So she's considered unclean, she's considered impure, she's sent off to be on her own, she's treated differently. So those are all things that have a bearing on her physical as well as emotional health. If you come to women of childbearing age, of course, we know that maternal and child health is a big problem. I'm not going to spend too much time on that. There's more than enough literature that you'll find uh, uh, available on the internet, and also, I mean, there's a lot of open source information that you can get there. In adulthood, we know that 50 to 90% of pregnant women in India go through some form of anemia, and that can be a major problem for those who don't have access to healthcare. And we have also disparity, like we said, in terms of who accesses health seeking behavior, and so on. And elderly women. Um, I will come to a statistic in a little while that even in a state like Kerala, a majority of the elderly people living alone are women, and they have all kinds of health related concerns and issues, and compounded by also gender. Okay, so while we talk about recipients of healthcare, let's also look at women in the health sector. Um, Again, going back to the socially prescribed role as carers, you find that we have a very, very high rate of absorption of women. And you'll find that a large proportion of the women in the public health system in India are employed as frontline workers. So you're all familiar with the ASHAs, the accredited social health activists, auxiliary nurse midwives, lady health visitors, Anganwadi workers, nurses. Majority of this workforce is made up of women, and these are the people on the front lines. But paradoxically and comparatively, the proportion of women in health policy making and health management positions is very low. So you can imagine what that disparity does. So while you have a lot of people deployed on the front lines to carry out some of the most, I would say, uh, incredible work that all of these women do, the decision makers still are largely men. And this is not just an Indian issue. This is an issue globally. So that does have a trickle down impact on what happens on the ground. Now, simple statistic, those of you who are familiar with our Arohan program, you know this also. Globally, 80% of caregivers are women, and not just professional. We're talking about family caregivers. Okay, so this is just something that is for you to know, that even in the state of Kerala, where services are far more accessible than in the rest of the country, men access palliative care more than women. So I'm going to speak more about palliative care now. So I'm going to go into a few case studies after this, just to highlight a couple of specific stories through which I hope to illustrate some of the things that I've talked about here. Gender equity and gender issues in healthcare is a very vast topic. And what I'm hoping to do today is to just sort of bring about a sense of awareness that this is a lens that we should be considering irrespective of our practice. And I don't mean this to be a rabid rant about how these inequities exist, but rather to acknowledge that inequities exist, and each of us can play a role in bridging some of those gaps. So, any reflections, any comments, any thoughts from anybody at this point before I go into the case studies? Please feel free to unmute yourselves.
Hi, Smriti. I'm sorry there might be disturbance in the background today.
That's all right.
Yeah. So yes, I have seen this inequality, working at a cancer hospital. I've seen it so often, especially women from low income, groups, families, where women are abandoned because the cost of the treatment is so high that midway the women are abandoned. Uh, so husbands just walk out on them, and I have seen cases where women are left stranded all by themselves with a small child with no support at all, because like you said, because they are women. Whereas the men, I mean, no disrespect to anyone here, but the men will have the undaunting support of the wife or the family members going through a similar kind of treatment. So I have seen it so often, Smriti, and it's very heartbreaking and very disheartening that our society doesn't raise more voices on these issues. So,
Thank you, Vandana. Thank you. It is very prevalent, and I think the first step towards even addressing a problem is to acknowledge that it exists. I know today that it is a very uncomfortable topic for a lot of people, and yes, the way that, there's a polarization in opinion, and personally, as a woman, sometimes I find that the language or the rhetoric that we adopt in order to address it actually does the issue more harm than good, because it at the end of the day it just becomes this huge brawl between the feminist factions and men at large, which is not entirely fair. But having said that, I think it's also important that we remember that some of it is so deep rooted and so internalized that this kind of a backlash sometimes is, I wouldn't say necessary, but it becomes the only way to be heard. And it's unfortunate that so many women are on the receiving end of this kind of inequity, and then they have to you know mobilize and and express themselves in the way that it sometimes comes out. Having said that, we're talking not about gender inequity at large. We're talking about gender inequity in healthcare, and particularly in palliative care, where we're going to go in just now. So,
Smriti, can I just speak of a
yeah,
case?
yeah,
There was my the bandwidth is very poor today, so unable to start the video. So
no
this
problem.
is there was a young 6-month-old baby with a retinoblastoma in the eye, and one eye was operated upon, and she was losing sight in the other eye. The mother was there standing, and when we spoke to her, we realized the father had walked out because it was a girl child, and they did not want to support the mother and the baby for the treatment. So, why I'm talking about this is I've seen that male children in under certain similar circumstances are provided for by the family because it's a male child.
Yeah, yeah.
So that is also very, very prevalent in healthcare, at least in the cancer settings.
I would say it's prevalent across the board, Vandana, and I'll be talking about some of the non-cancer scenarios in which this is so blatantly, obvious. But it is that, and I would say that there is this. I mean, we cannot, for a moment, disentangle like I said, the intersectionality, because what we see in healthcare is only a snapshot of the larger interaction socially, culturally, and what has been the norm for so long, and that plays out in these kind of scenarios. So thank you for sharing that. And Rajni has made a really important point about decision making, that even something as that is so deeply personally intimate for a woman is a decision taken not by her but by a male member of the family. And uh, well, there are cases when the woman is undergoing treatment, husband leaves the wife. Yeah, well, there are different ways of looking at that also. Um, we find that in a lot of cases where we have, you know, men with spinal cord trauma, young men with spinal cord trauma who've just recently been married, the woman is his primary caregiver for the rest of his life, that he is going to be using a wheelchair, or he's going through his rehabilitation and all of that. And so often in our experience we find that the husband is deeply suspicious of his wife's whereabouts. And Manisha, I don't know if you, because you've worked a lot with that patient group. My experience there was that the woman is 24/7 looking after him, but because she's healthy, because she's able to move around and he's not, there is a sort of shadow that's cast on her character of, okay, she's not getting what she needs from this man, so she must be wandering. There's an assumption that comes in which may be completely wrong, but then she has to go out of her way to explain herself, to explain her whereabouts, to explain why she's doing what she's doing. And it's a very double bind kind of situation, because she's the one who can actually go out and get the groceries, she can go out and get the stuff that is needed in the house, but then that is looked at suspiciously. Manisha, have you come across stories like that?
Yes, ma'am. There have been cases like that. Yes, definitely.
And a significant number, I would say. It's not a rare it's not a rare thing that we see. I think it's
It
a
happens mostly in most of the cases.
Yeah, it happens a lot. So yeah, so health issues are so deeply connected, like I said, to social issues, but also to intimate issues. And we also know, unfortunately, of cases where um, a woman who has high dependency needs is also the victim of abuse, both physical abuse as well as sexual abuse, and she has nowhere else to go. So I mean, the examples are there are 1,000 examples, and it's very unfortunate that we see a lot of that happening, but it's what happens. So all right, I'm just coming back to the presentation now. Sorry. So, example of Amreen. Here's a classic example, Vandana, like you were talking about. She gave birth to a child with a congenital anomaly, and she was abandoned by her husband. So sorry. Okay, so what happens here typically is that, first of all, the woman has not been educated herself. She um, she was not prioritized as a child to be educated. Came from a poor family, married into this family, gives birth to a child with cerebral palsy, and the superstition and the stigma and all of that lead to her being seen as the cause for the child's condition. And the family has then at that point decided that she's damaged goods, and the husband needs to probably go and get married somewhere else. And so she gets abandoned. She's young herself, and she has a child with high dependency. She's not educated. She can't get a decent job, and she can't even leave the child because there's no other carer. So you can imagine the kind of situation that she finds herself. So, in a situation like this, there are things that can be done for her, and I'll come back into that in a little while. We had another patient not a patient. We had another woman we came across who had two children with autoimmune illness. And because both of them had an autoimmune illness, there was pressure on her to have one more healthy child, at least have one more healthy child, someone that the family can be proud of, someone that is a normal child that will take forward the legacy of the family. That was what she was told. And you can imagine that she's a woman who is the main caregiver to these two children. And we know that even with two healthy children, when they're toddlers, how, or when they're young, or at whatever age they may be, what a lot of pressure it is on the mother. But to have two unwell children and then to be put pressure on by the rest of the family, saying that she has to produce a healthy child, a lot of emotional trauma, a lot of emotional pressure, and quite a statement on reproductive rights. So she, at the end of it, felt that she actually had no choice. If she was to have any peace in the family, she would have to go along with the in-laws' wishes and her own family's wishes, because everyone felt that way. And she said to us, "But that means I have to take care of three children." And she also had the fear that what if the third child also had this condition? Then what would happen to her? Because she was convinced that at that point, she would be held responsible and she would be left with three children with autoimmune illness to look after. Not an easy, not an easy constellation of symptoms to take care of, expensive treatment, and then she would be left on her own. So this was another case that we had seen. I've changed the names of all the women. These are not their real names. We found that she had chronic pain. Her husband had hypertension and diabetes, but resources for healthcare were spent on him as he was the breadwinner and therefore more valuable. And her chronic pain was, after a while, as it happens with a lot of chronic pain sufferers, just ascribed to psychosomatic, attention seeking, all of that. So deprioritized completely, and whatever money that was kept aside was saved towards healthcare expenditure was was spent on the husband. Another example that I'm going to give you is of this person who I personally counseled. She was she was based out of Madhya Pradesh when she got in touch with me. She had recently been married in Maharashtra. Both she and her husband were techies. Her career was just sort of taking off. She was in her mid-20s, mid to late 20s, and this was an arranged marriage. The mother-in-law fell sick soon after the marriage. She became bedridden, and this girl was asked to quit her job and become a caregiver. um, Actually, I'm mixing up two different stories, but I guess because it's such a common scenario. So there were two cases actually. One was the one that I just told you about. You can ignore the part that says patient incontinent. That's another story. But in the case of the girl I was talking about, um, she didn't know her in-laws very well. She'd only met them maybe twice before her marriage. She goes into that house. The husband remains in Maharashtra, in Pune. She's in this smaller town in Madhya Pradesh, looking after a mother-in-law who was completely bedridden, and she didn't see her husband for about 8 9 months because he was so busy working, and he had to work extra hard to earn enough to also support the treatment costs and all of that. And this lady called me once a week just to talk about how difficult it was for her and how she hadn't even made friends because that was not her hometown. It was not the city that she grew up in. She didn't know anybody in that place, and she also mourned the loss of her career. And she said, "I don't know if I can ever go back to because I think I'm losing out on opportunities. I'm certainly losing out on the promotions, and I don't think that same company is going to take me again." The other parallel case was someone from a low income background, who is is the case that I'm talking about here, where the mother-in-law again was sick, and she was incontinent. And this girl actually developed this habit, an OCD, because she was constantly washing her hands. And because she had to constantly clean up after her mother, mother-in-law, she felt, um, quite repulsed by the fact that she was constantly handling her excrement and was constantly having to clean her up. And when our team actually went to see her, she had all these blisters between her fingers, these like fungating blisters, and she just never had any time to go see a doctor. So at that point, what our team did was we treated her hands as well, and then we gave her surgical gloves and things to use. And of course, we looked after. We started caring for the mother-in-law as well, and that's when Meenakshi's life became a little bit easier. The other girl who I talked about, who moved cities, actually she couldn't do anything till her mother-in-law died, and it was a protracted illness of over 2 years. And at the end of 2 years, when the mother-in-law finally died, is when she was able to go back and join her husband. But by then, she was already quite worried about her father-in-law, because now the father-in-law was unwell and sick, and he had just lost his wife. So then, she was like, I may as well just stay here, because there's no point me going back into Pune and getting a job, because I think within a few months I'm going to have to quit it and come back here. So what's the point? So those were just two very parallel stories that emerged pretty much at the same time, I recall. So here's what palliative care can do. We recognize the invisible patient, as we have talked about on several occasions, and especially as caregivers. And once we acknowledge that, then we can't unsee it. So the next time we see a patient, we know that we also have to look at the invisible patients in the family. And most certainly, you will find that there's a good chance that the invisible patient in the family is a woman. So one of the things we also try to do is provide vocational rehabilitation for women who are forced to fend for themselves, especially in the case of those young mothers looking after children with high dependency needs, cannot leave the house, cannot go out and earn, cannot work, don't have social support. At that point in time, getting them trained in some sort of cottage industry activity, which will allow them at least some sort of income while they're at home. So whether it's stitching and sewing, whether it's um, making, I mean, and it has to be, it cannot be labor intensive, because she already has other duties towards her child. So in Kerala, we've done a successful run with umbrella making and things like that, things that are easy to do. It's not a huge income, but at least it gets her by. And there are lots of different ways to get innovative with this, tie up with other groups like Kudambashri and all of that, and then get, and this is empowerment. So when we talked about gender equity, gender equality, this is also an empowerment, where we enable people to take control of their lives, to take control of their decision making powers, and to be able to make decisions for themselves. Of course, providing emotional support is very important. We find a lot of the times that the invisible patient, especially, is never heard. Nobody has, up until that point, sat down with the wife of the man with spinal cord trauma and asked her how she feels, what's going on with her. Uh, is she disappointed at how things have turned out? Is she traumatized? What about her needs? Uh, has anyone ever talked to her about that? What about the fact that now, because her husband is unable to uh, engage in sexual activity, she cannot become a mother. So what about that loss? What about that grief that she might have? That might have been a dream that she harbored. So just to acknowledge and provide emotional support along those lines can actually go a long way in mitigating some of the suffering, because we find that a huge percentage, or we have a huge percentage of suicide amongst women because of healthcare inequity in India. And of course, mobilize psychosocial support by way of women's groups, and getting them access to legal aid and also to subsidies. Now, a woman who is already steeped in all kinds of burdens that she's carrying may not have the proclivity to go out and find social support for herself. There might be women's groups around, but she has no access to them. She has no way of getting to them because she just can't leave the house. So we mobilize that, make that last mile connection between them. A woman, because she's not educated, may not know what subsidies are available to her. So that's where the social worker and the counselor become extremely essential in connecting her to those subsidies and connecting her to legal aid if she needs it. And we have done that at Pallium a few times, where we have enabled and facilitated legal aid for women who are going through terribly difficult times within their own families because of a health related issue within the family. And I mean, those are complicated cases, so we don't get too deeply involved, but we certainly do mobilize some sort of help for them, because it's impossible to go into a household, just treat the patient, and be and ignore everything else that is going on there. So when we say that the family is the unit of care, then these are things that we also look into. Support the educational needs of children if possible. Not every organization undertakes this because it's seen as outside of the scope of palliative care, but it's very much within the scope. And if we ourselves can't run a parallel program to support the educational needs, then certainly we can put the word out to funders, to people who might want to support these kind of activities. And there are more than enough organizations across the country that look into this. And it's high time, I personally feel, that there are cross-sector alliances that are made between palliative care organizations and individuals and others who are providing the service that we may not have the bandwidth to provide. So those of you who are in Bangalore, you should definitely look up an organization called Dream a Dream, where they work with individuals, where they work with young people, children, from you know families that are distressed on different levels, and the child is growing up with a lot of adverse childhood events. If you remember Isabel's presentation from last week, she talked about adverse childhood events, and Dream a Dream is quite dedicated to helping them overcome those childhood adverse events and experiences. So look outside the echo chamber, look outside to see who else is doing the work, and perhaps then link the families to those organizations, and recognize that mental health as an integral part of palliative care. So the definition of palliative care is changing, and it's changing rapidly, especially in low and middle income countries like ours, where we have no choice but to look after so many different needs that people have, that in other countries may well be taken care of by a social security system or some other form of support that they get, social support network that they have. But in some of our countries, that's not the case. So traditionally, again, mental health was not considered to be under the ambit of palliative care specifically, but it's very much a part of the service delivery that uh, model that we undertake. Okay. Just to give you an example, we have a program called Ujwal that we run at Pallium India, and it deals with gender-based issues of not just the patients, but also of caregivers and the bereaved. And Ujwal has been running for a couple of years, and uh, it's supported, actually it's a project that's supported by a women's group in the US, a group of Malayali women in the US who felt that this is something that is close to their hearts and they want to support. So under Project Ujwal, we strengthen existing support structures available to women. We help them access opportunities for empowerment, and we reduce stressors and barriers to their well-being, including facilitating legal aid. And how Ujwal is structured is that every woman who comes into the Ujwal program is assessed along four parameters, where we see, does she have access to basic food, water, clothing, shelter? Uh, is that where she needs help? Um, and this could very well be the caregiver. And the second thing is, does this person need any medical procedures, interventions, or any physical aids that might help them deal with the illness better? The third is vocational rehabilitation. Do they need to be financially uplifted? And if that's the case, then how can we bring about a change in that sphere of their lives? And we look into the educational needs of children, because a lot of women are very distressed by the fact that their child has been pulled out of school and has lost out on educational opportunities. And that's because somebody in the family is sick and she can't do anything about it. Those are the four major areas under which we assess beneficiaries. And then we have a committee of about 8 people who review these cases on a bi-weekly basis, and so the turnaround time is fast. So we assess it, we ensure that we review it in a way that is appropriate, and then try and give them the appropriate kind of support mechanism that they need. And like I said, we provide medical and procedural support, vocational rehabilitation, education needs of the children, and assist with securing basic amenities like food, water, and shelter. What does this have to do with palliative care? Everything. There's If I give them just medical and procedural support, but they're actually starving, then that's not the complete picture. So we found that a lot of women were having difficulty accessing water, where they were the primary caregiver, but they had to walk long distances with a bucket, with a uh, with those you know what I'm talking about, and going long distances, filling water, coming back, and that was also having an impact on their health. I know of a woman who uh, the one who had two children with juvenile rheumatoid arthritis, and she had to keep carrying her son everywhere, but after a while the son got too heavy, but she still had to carry him because she didn't have a wheelchair for him. And she has now chronic back related issues, so that has affected her health as well. So under Project Ujjwal, we try and diminish suffering on all these different domains, and wherever possible we also help them repair or rebuild or rent homes in safe neighborhoods. We've done this with a few women. We had a lady who was looking after two children. Her husband had his own issues. They were not getting along. She was the victim of a lot of abuse, and on top of that, she had a child who had another autoimmune condition, and she was scared to leave the child alone with the father and go out and work. And there were all kinds of social issues that were happening. The father's friends would come across, just to get drunk with the father. The child safety was in question. So finally, we also helped facilitate uh, getting her a home in a safer neighborhood, and that made a world of difference to her health in general. So there are various ways in which we can engage, and of course there are direct palliative care interventions that we provided. So here's one of the statistics that I was talking about earlier, that in India, an India population study in 2014 showed that in Kerala alone, 1,70,000 people above the age of 60 live alone in single person households. And of these, nearly 1,43,000 are women. And this is an intersectionality of an older population of women living alone. And their health needs are severely marginalized. So when we consider the intersectionality in marginalized groups that even make them even more vulnerable, we need to remember that there are women, there are children, there are the elderly, there are prisoners, there are people with mental health conditions, there are people with disabilities, and all of these, uh, there is an intersection of this that happens also, and it can be devastating for the person in the center of this Venn diagram. And health is also associated with social factors, is also associated with cultural factors, political and policy related factors. So all of these different things come together to form a very difficult situation for a lot of people in our communities. And again, I will take this back to the fact that that doesn't just apply to women, but it also applies to people from other genders and from the LGBTQIA community. So I'm going to just stop there. This is just introduction to the idea of gender and gender inequity, and I'm happy to take questions, comments. I'm just going through the comment section. Okay, so a lot of observations, pretty much affirmations, but I'd like to, we have about 15 minutes. So if any of you would like to pick up on a particular point and discuss it, then I'm very happy to do that with you. Please feel free to switch on your cameras and to unmute yourselves. Uncharacteristically quiet this group is being today, which I don't know if I should be worried about. Okay, so I can see Linda. Okay. So one is to actually acknowledge that this problem exists, but I think the next step is the step to think about, which is how do we play a role in um, alleviating some of this. We can't change, a system that is thousands of years old entirely. But I think, like they say with the starfish story, that with every small change that we make, we are impacting the system at large. So, in your own practices, whether it's in palliative care settings or general healthcare settings, caregiving settings, um, if we can bring a gender lens into it and be more sensitive to the fact that different people have different needs, and it's not just about equality, but it's about equity, and it's about respect. So if we can, you know cultivate that on a daily basis, which I know that almost everyone in this group is probably doing on a regular basis. But I hope that with today's session, a little bit has, maybe you've picked up something new. I really hope you have. I'm going to be sharing with all of you some of the uh, more current articles and resources available about gender equity related issues in healthcare. Maybe that'll give you a snapshot and perhaps um, evoke a few new ideas in your own practice. So that's something that I'll be sharing with Manisha, who will then be sharing it with the rest of you a little later in the week. So, Manisha, if there are no more comments,
Okay, ma'am, shall we wind up the session then? Shall we wind up?
absolutely, I'm absolutely
There's
fine
some
with it. I'm
comments from Avtar, no?
He's just dealt with a difficult situation.
Okay.
So yeah, I think these are cases and conversations that we can have. I sense that the group has probably had a long day anyway. 6:30 is a very late ending to a day, so I'm not going to push it any further. Happy to take any questions offline, should any of you have any. And thank you. Tomorrow we have a great session with Dr. Seema Rao on dignity therapy. So that is at a more civilized hour of 3 to 4:30. So I hope you enjoy that. So with that, shall we sign out, Manisha, for now?
Yes, ma'am. Thank you so much for being with us and taking the session for us. And thanks
My pleasure.
everyone for being there and attending even in this time. Uh,
Yes. Thank you
yes,
so
and
much.
finally, we have a last comment from Vandana. The change can start from our homes, changing the mindset of our children, educating our children, both sons and daughters. So thank you,
Absolutely.
everyone.
Absolutely.
Thank you.
Thank you. Have a good
See
evening.
you all tomorrow.
See you tomorrow.
Bye bye.